Welcome to the Doc Lounge Podcast, Crazy Cases series. In this series, we will explore some of the most unusual and interesting cases medicine has ever seen. We will speak with providers of all specialties from all over the nation. We will hear first-hand accounts from symptoms to treatments to cures. So sit back, relax, and let's explore some crazy cases. Hello, everyone. Thank you guys for tuning in to the Crazy Cases series of our Doc Lounge podcast. I am your host, Summer Gilbert, and my co-host today is our EVP of Business Development here at Pacific Companies, Mr. Patrick Deeny. Thanks, Patrick, for joining me today.
It's my pleasure. I'm happy to be here.
Our guest today is Dr. Ira Ellis. Dr. Ellis is board certified in family medicine, obesity, hospice, and addiction. Got a lot of qualifications there, and he graduated from the University of Tennessee, and he's still practicing in Tennessee to this day. Dr. Ellis is definitely a great guest for the show. He has a ton of cases, so many that it was hard to choose, so he let Patrick and I choose which one he would talk about today. So we chose one case that kind of led into another case, and we're so happy that we did. When you listen, it's extremely different than you think it's going to be. And a quick reminder, all our Crazy Cases episodes are HIPAA compliant, no patient names are shared. So with that being said, without further ado, here's our conversation with Dr. Ira Ellis. All right, well, first of all, Dr. Ellis, thank you for joining us on the Doc Lounge podcast.
Thanks for having me.
No problem. It's our pleasure. I'm really excited for this episode, so let's just jump right into it. Let's talk about these cases.
Okay, so I was a full-time faculty member at a family medicine program for several years, about 13 years. And we're the only residency program in a hospital system. I think it's like a 600-bed hospital. And we basically do everything except burns and transplants. So basically we're internal medicine and family medicine and OB and everything. So just as that is a basis. So I was probably a second or third year faculty, maybe even fourth or fifth year faculty. And one of my new third year senior residents had contacted me and said, I'm up this afternoon for my first kind of senior responsibility. I'm kind of nervous, stay kind of close because I just don't really feel sure of myself. And I said, okay, that's fine. So I was hanging around the hospital that afternoon and I got a call from the third year. And he said, we've got this lady down here to admit, and it's just a weird situation. I'm not sure. I need you to come look at her. So, okay, that's fine. So, 3-minute walk downstairs. And so I said, okay, what's going on? So the senior resident said, okay, here's the presentation. We've got a African-American lady in her early 40s, has had some issues with recurrent pneumonia over the last month. She's gotten worse and she's brought to the ER by her mother. ER doctor saw her, thinks she needs to be admitted, but it just doesn't make sense. Okay, so I don't know if this is just someone who is in, shock that they actually have to kind of be the boss now, or if this is, what's going on. So, okay. So I just go into the room with the residents, and there's this really well-kept, thin but healthy-looking African-American lady laying in the bed, kind of resting. Her mother was with her, sitting at the bedside. She's probably mid-60s, very well-kept, pleasant. I remember, very pleasant lady. And I just, asked, hey, what's been going on? And the patient herself was more, she would open her eyes and smile and say thanks and hello and yes, but not really able to give a history. So the mother said, this is my daughter, and she's been having issues with pneumonia. And she described that as she's been having issues with cough and shortness of breath and just not feeling well for a month. And she was diagnosed with pneumonia 2 to 3 weeks ago, did a course of antibiotics, maybe felt a little better, went back. They said, yeah, probably need another course of antibiotics. Got another course of antibiotics and still wasn't doing very well. And this time they came to the big hospital. I said, okay, does your daughter have any major health issues, any other issues? She had her gallbladder out when she was in her early 20s. for gallstones. But no, otherwise she's healthy. She's active. She jogs. She doesn't smoke, doesn't drink. She's married. She has 2 children. Her husband's in the military, and I think he was deployed at the time, and the 2 children were probably in school. It's probably 1 in the afternoon. They're probably at school. And I said, okay. So we, examined her, and she was just kind of lethargic. I mean, nothing really stood out. She didn't look, she wasn't in respiratory distress. She was just kind of ill appearing, but, nothing out of the ordinary. Her lung sounds were good. Her heart sounds were good. She wasn't tachycardic. So I thought, yeah, this is a strange pneumonia. So we went, and this is probably about 2 years before electronic medical records and electronic data was a standard. So we were still getting paper results and everything. Mm-hmm. So I went back and I said, well, let's pull up her labs. Let's look at her x-rays. Let's look at all this. She had her blood work was essentially normal. She did have a slight elevation in her white blood cell count, maybe 13,000, nothing extraordinary. Her chest x-ray was abnormal. She did have this infiltrate appearing, this abnormal, opacification in her left lung. It looked like multi-lobar. And it was read as multi-lobar infiltrate by the radiologist who overread the ER doctor's reports. And I thought, yeah, I understand. This doesn't really look like a pneumonia, or it looks like a pneumonia, but doesn't make, it's not classic. It's definitely not a classic pneumonia. So I thought, okay, well, how are her vital signs? Well, she's afebrile. She's not tachycardic. Blood pressure's a little low, 88 over, say, 60. But her mean arterial pressure was right around 60. But she's thin. And, in some smaller framed people, you see that. So I thought, yeah, I'm not sure what's going on either. Is it pneumonia? Maybe. I don't know. They'd ordered the blood cultures and, everything. So she's in the process of being worked up. And so I went and talked to the emergency room doctor, who's 20 years experience, and said, do you think this could be anything else? Because, nothing is impressive for pneumonia. She's got an abnormal chest x-ray. But, I don't know that I would just say this is, it's an easy something to write down. But I just don't know. So he said, yeah, I just think, she's probably got an atypical pneumonia. She's relatively young. Okay. So I go back to talk to the mother. And, we explained, okay, we're going to admit your daughter to the hospital. She may be here a day or two. We're going to get blood work. Obviously, if there's any decline in her respiratory status, she may need to have to be intubated, or I think we were using BiPAP a little more frequently back then. But anyway, we may need to intervene. She gives permission, do whatever you have to do. And very religious kind of family, we kind of believe whatever happens, and you just do what you have to do. Okay. So while we're having the conversation, the oxygen saturation alarm starts to go off. She's starting to desaturate. So we kind of do a little sternal rub, wake her up. She recovers, but then as soon as she kind of gets stuporous, that O2 sat drops again. So I'm trying not to be the main decision maker. I'm trying to have the third year kind of step in and do his duties as the senior. And so I just looked at him and said, hey, what do you think we need to do here? She's dropping in the mid 80s whenever she closes her eyes and tries to go to sleep. And he was like, maybe we should just intubate her. And I said, well, obviously we don't know what's going on. Number one, we don't know what's going on. Number two, we don't know what's going on. And so we can't predict what's going to happen next. So yeah, I think the best course of action would be to just go ahead and intubate this lady. Her blood pressure's low. Not the worst I've ever seen, but yeah, this doesn't make sense. I don't know how to control the situation because I don't have a diagnosis. So we, talked to the mother really quickly and said, listen, we're just going to go ahead and put your daughter on a ventilator and get this sorted out. Okay. So the respiratory care team comes shuffling in, and the standard at our hospital for the induction for a elective intubation was Versed. And so they were drawing up the Versed and everything. And for some reason, the residents looked at the mother and said, now your daughter doesn't have any allergies. You said she's healthy and doesn't have any problems. And they're like, she said, well, when she had that surgery for her gallbladder, they told us not to ever use something with a B, benzos. She doesn't do good with benzos.
Mm-hmm.
And I said, okay, well, all right, let's not use the Versed. So what other options do we have? So the resident, the third-year resident, he said, well, we could use a paralytic. And I said, yeah, you could, but then the lady can't breathe. She's paralyzed. She's going to be anxious. She's going to be, as aware as she is now.
Yeah.
So, we
wow.
don't really use paralytics like that. You could. I said, yeah, you could, but that would be cruel and unusual punishment. So let's anything else. And so he said, well, and so this was when propofol was making its big,
Sure.
it just kind of, yeah. And so they said, well, we have this propofol stuff, and it does everything. It's an analgesic, it's an anxiolytic, it's a paralytic essentially. So it's kind of the best of all the worlds we were looking for here. But at that time, the only people who could give an IV push of the propofol were medical doctors. They wouldn't allow nurses to push. And even in the ICUs, if you were using it for ventilated patients, there was some kind of protocol where the critical care doctors had to be present. I don't know. But anyway, they said, all right, well, Dr. Ellis, you're the attending physician. You have to push the propofol to, so we can get this intubation done. And I said, okay, that's fine. So we got everything hooked up, had our flushes ready, and like a tenth of a cc of propofol and just asystole.
Oh, no.
Immediate. And I'm
boy.
talking about, asystole. And I just said, whoa. And of course, I knew immediately what the diagnosis was. Y'all have any idea?
I have no idea.
No.
Okay. So I knew immediately what it was. And so, of course, so you got the mother sitting 3 feet away, reading the newspaper. You've got every medically trained person in the room's jaws hitting the floor. And the residents' eyes are bugging out of their head. And I thought, oh, all right, start CPR. You start chest compressions, get the bag going, let's go. And so I said, and we probably just need to go ahead and intubate her since, we're in asystole. So they're in the process of doing all that. And I come out to the ER doctor and I said, I know what's wrong with her. And we need a pericardiocentesis kit. She's got tamponade. And that abnormal x-ray, that opacity on the left side it's not an infiltrate, that's her heart. And so that's the problem. She's short of breath, she's fatigued because her heart's not beating, her blood pressure's low. And I just took away the little bit of blood pressure support that she had with my propofol.
Oh, geez.
All right. So now you get into the whole pecking order and ego. And the ER doctor said, no, you're wrong. And I was like, well, okay, but there's only one way to find out. We need to do a pericardiocentesis immediately. And he said, yeah, but you don't have those privileges. So there's not going to be a pericardiocentesis performed. And I said, well, unless you have another diagnosis that would explain why she would go into asystole instantly, I think we should do one. He said, she's allergic to propofol. It's an anaphylactic response to propofol. And I said, see, the trick with that is the anaphylactic reaction is usually your second exposure or third exposure. She's never been exposed to propofol. This is no. I said, now could it be just total bad luck? Yeah, but no, I've never seen anybody have a reaction that is instantaneous. This was instantaneous.
Mm-hmm.
And so he kind of looked at me for a second, kind of looked in the room. And of course, it sounds like it's 30 minutes, but it's like, a minute.
Yeah.
Right.
And he said, okay, he said, hey, all right, give me a pericardiocentesis tray. So sure enough, they got 4 liters of fluid out of the pericardial sac. Before, just copious amounts of pericardial fluid from the pericardiocentesis. So, and of course, her heartbeat comes back instantly, sinus rhythm. We have her intubated and everything. Of course, now we got to figure out what's going on. Now, the 4 liters that they pulled off went into just a non, it was not aseptic technique. Obviously, it was more of a rough kind of situation. So now it was, at that time, it was me, the 2 or 3 residents, the ER staff, and I think I had like 4 medical students, 4 third-year medical students who are doing a family medicine rotation, who think they're going to be talking to people about diabetes and smoking cessation. Yeah, and we're basically doing internal medicine, if not critical care, you know. So this was, again, about 2 p.m. So obviously, you know, prioritize things, get the oxygen, get the blood pressure, get everything stabilized, get her up to an intensive care room. Let's figure out what's going on. So not a whole lot of more information after that. So we convened the next morning about 5 a.m., 6 a.m. So we reconvened the next morning because we would around in the hospital in the morning, then we would go to our family medicine clinic. So we reconvened that next morning and go to the intensive care unit. And we have about a 24-bed intensive care unit. And then we have like a 24-bed surgical intensive care unit and that kind of thing. So anyway, we go up, and I've got my, you know, my little ducklings following me around here, and the same 4 from that afternoon before. And we go up, and we're going towards the room, and what year was this? 2007, 2008. So there's still a generation of what I call old-fashioned doctors at work. They're just there in the hospital. They don't ever really exist outside the hospital. And I saw this older guy. He's still working today, but he was probably 70 years old then. Real nice older guy. He was I think he was oncology originally, but he was transitioned over to hospice or something. But anyway, real nice older guy, real, you know, just anything I can do to help you at any time, give me a call kind of guy. So I see him, and he's one of these older generation guys that remembers everyone's name, calls you, you know, he would call me Ira. He said, "Good morning, Ira. How are you? Are you any good cases today?" That was his general kind of thing. So he comes, and he looks kind of like a character out of a Norman Rockwell painting. He's real thin, got the big, you know, the big Adam's apple.
Pitchfork.
Yeah, well, yeah, he looked like he would have played baseball and basketball. Anything a tall, lanky white guy would have done in the 40s and 50s. But again, anyway, so he's walking up, and, you know, his whole body moves. You know, he swings his arms, just real character. Anyway, so I see him, and I'm getting ready to say good morning, you know, and I'm getting ready to get my good morning. And he comes up, and he literally stops and puts his hand on my shoulder, and he says, "You didn't do anything wrong." And I thought, that's odd. What are we talking about here? And I said, "I'm sorry." And who knows? You know, who knows what the punchline is going to be? Yeah. And I said, "I'm sorry." And he said, "Yeah, this lady over here that y'all got in the hospital yesterday, you didn't do anything wrong." And I thought, why are we talking about this lady? So come to find out, he was on call the night before, and the fluid was sent, and it was stage 4 breast cancer.
Oh, wow.
Whoa.
It was, yep. So what he had done, 11 o'clock at night, I guess the pathology did their, you know, they call them the cold slides, or just a quick look or whatever. The pathologist, who was just like him, the old-fashioned dude that doesn't really go home unless things are done, he saw something in the cytology that looked like breast cancer. He did some more tests, said, "Yeah, I think this is a breast cancer." Called the ICU. He said, "Hey, does this lady have any signs or symptoms of breast cancer?" They go in. I guess they do a breast exam on the lady at midnight. They don't really feel anything, but they get a radiology tech to go up there, do an ultrasound, find a bump somewhere in her breast. Call the oncologist at like 1:30 in the morning. He comes in on call to do a consult at like 2:30 a.m. He looks at the picture, says, "Yes, this is, while not diagnostic, an ultrasound is not diagnostic." He said, "Yeah, this is consistent with a breast cancer. The fluid sample has breast cancer cells. She's got stage 4 terminal breast cancer with no other manifestations."
Wow.
And he said, here's what would have happened. She would have died in her sleep. And family would have, you know, refused an autopsy, because in the Bible Belt, I'm in the the traditional Bible Belt. Most people
Sure.
don't get autopsies. They just say, well, it's God's will. They passed on, or they call the medical examiner, and if there's not an extra hole somewhere, they're like, PE, MI, kind of thing. So he said, yeah, she was bound to die young. This is not, he said, yeah. So she had stage 4 breast cancer, the metastasis to the pericardium. He said, what most people would have done is they wouldn't have had a mother or someone to help them out like she did. And they would have just that blood pressure would have eventually dropped, and they would have hypoperfused and had a heart attack and died.
Yeah. Wow.
Yeah. So it was a stage 4 breast cancer presenting as atypical pneumonia. Now, sad part of that is she never woke up. She had irreparable brain damage from the CPR event. And she was taken off life support about 2 days later, and she passed away.
Oh, man.
Sad, but according to this guy, he said, listen, I'm surprised because he had, he's old fashioned. So he actually called the residents on call. Of course, this was the talk of the town, this whole event. So he had got the whole backstory from the ICU nurses. He had called the ER and talked to the respiratory therapist. And he said, I'm impressed that you would have even thought to have done the pericardiocentesis. And it's really funny because a thing I used to teach is when you do your ACLS protocols, and you're looking at your reversible causes of asystole, tamponade is in that's one of the T's. Yet in a traditional CPR situation or a ACLS situation, how many times do we perform a pericardiocentesis before we stop? Yeah. The answer is rarely, if ever. And I actually had read an article not long before that where Johns Hopkins was one of the last hospitals or teaching hospitals that their CPR team protocol said you cannot stop with asystole until you've done a pericardiocentesis. Oh. Because it is more common than we think, and it can literally be reversed. Yeah. So anyway, weird case, crazy case. Now we segue into case 2. So I get my pat on the back, it's terrible. Medicine's a hard business, and you did everything you could. Obviously, it would have been a better situation to figure out what was going on before I pushed the propofol. But that, he basically gave me a pep talk, the oncologist. And so then we went in and did our examination. It was back in those days, there was no families allowed into the ICUs until certain visitation hours. So there was no family to talk to. And we were just kind of, man, this is crazy and whatever. So I'm in the room with the students. Her nurse, ICU nurse, comes in the room and is like, hey, this is the craziest thing. And yeah, this is so sad. Because again, she was like 41. And I think her children were only like 12 and 13 or something terrible. And her husband had to be called back. He was deployed. Anyway, so we're talking about all that. And she said, hey, before y'all go, come tell me how to treat this nosebleed. Oh, and I said, nosebleed. Okay, sure. I'm in the ICU. I'm a family medicine doctor. Let me treat, severe epistaxis in the ICU. That's what I signed up for. Let's go. So we literally go 2 doors down. And I have no idea who. I said, so is this my patient? This may have actually been before HIPAA was a thing. Yeah. So I said, is this my patient? She said, well, actually, she was admitted to your service overnight. So yeah, she's next probably on your list. You just probably haven't even paid attention. I said, okay, so what's happening? And they said, well, she was admitted last night, and we just got her in the room and everything. And I noticed her nose is bleeding, and I can't get it to really stop. It's not terrible, but I don't know what to do. And I thought, okay, so go into the room, me and my little trail of students here, who again, family medicine rotation. They've already seen this other thing. So we go into the room, and it's an overweight African-American female, obviously just obtunded. She's just kind of lethargic, kind of muttering as if she's having a conversation, but she's obviously not having a conversation with anybody that we can see. And sure enough, she's got some, bloody discharge from her nose. And I thought, well, I've seen pretty bad nosebleeds, and this isn't the worst. And I'm thinking this is just an ICU nurse who hasn't dealt with it, but I'm thinking you don't do anything. You just kind of watch it. And so I was like, okay, well, what's the information here? Because we don't have, I don't think at that time we maybe could access labs, but I think we still had paper charts.
Mm-hmm.
So I said, let me see her chart. So they hand me a plastic chart flip it open, and it's an empty plastic chart because the information hadn't been transferred from the ER yet.
Oh.
And I thought, well, this is not helpful. So what's the story? And she said, well, she's a frequent flyer for DKA. And she usually comes in about once every month with a blood sugar in the 800 range. We put her on, some insulin, and, 4 or 5 hours later, it corrects, and then she eats, and, standard protocol, usually out of the hospital in a day or two. And I think she had some kind of falling out with her prior PCP. So she was actually admitted. I don't know what terminology y'all use. We call them unassigned or drop-in.
Sure.
So we had no real history on her other than what would have been in the hospital, which had to be requested for medical records, which hadn't arrived yet. Mm-hmm. So basically, someone somewhere had admitted her for some problem, probably DKA, as she was on an insulin drip. Okay. So I thought, okay, well, she's DKA, and she's probably acidotic, and that's probably explains the confusion or the encephalopathy or whatever you want to call it. And I said, okay, that's fine. And so I said, well, let's look at her extremities, be sure we don't have anything going on. So we did an exam on her, and I was just watch the nosebleed, because I need to get her records before I make any big decisions. I need to get her labs, all this. And so the nurse is like, okay. So one of the medical students says, hey, something about the viscosity. They were like, this is really thin to be a nosebleed. This is almost like allergies, like when you have real bad, I think they call it like a runny nose, like coryza.
Sure.
The old-fashioned medical term, when everything's kind of congested.
Yeah.
She said that looks like she's just got nasal drip. And I said, yeah, I'm not sure. So I asked the nurse, I said, now, is there anything in particular you're worried about? She said, well, I'm just afraid if she deteriorates and we need to intubate, a lot of times with the nosebleeds, they'll get a clot like in the pharynx, and that'll occlude, and it gets to be a problem. And I was like, oh, okay, I didn't think of that. Well, let's look in her mouth. So we kind of got her mouth open, and she was lethargic enough that we could do that without her biting down or anything. And sure enough, she had a clot forming on the soft palate, that where it just kind of accumulated. And I said, yeah, you're right. I said, she's got like a real loose kind of, clot forming back here, and she could very well aspirate. So what do y'all do when y'all see them? She said, well, it's not very scientific. We just basically put on gloves and kind of fish it out with a 4x4. Okay. Well, I'll help you do that, So I get my gloves on and everything. And I said, not that I'm the most manly man, but my hands were pretty big. And I said, let me just have the 4x4 and I'll scrape this clot out. She said, okay. So she hands me the 4x4, and I put the 4x4 in, and I can kind of get it on just in front of the uvula, to kind of help this thing out. And as I pull kind of towards the top of her head and forward, my 2 fingers go through her hard palate.
Oh my gosh.
To the knuckle.
Ooh.
So do you know this diagnosis?
Not a clue. I'm kind of afraid to find out.
Okay. So I knew what this was. And I said, of course, the nurse literally almost passed out.
Yeah.
I almost passed out, but I was like, oh my God. Now, of course, I jerked my hand back, and I was shocked at the fact that when it happened, there was no resistance to my fingers. And the students, again, eyes bulged, what in the world? And here's the interesting part. The lady was just as kind of out of it as she had been. No other, whatever. And so I said, I know what this is, and it's not good, but I've never seen it before. So I spun around, walked out, and of course now it's a little bit later. It's around 6 a.m. So some of the private folks are kind of meandering to see their patients. And I saw one of our wonderful infectious disease doctors, who's a Filipino lady who trained, I think her and her cousin, she's related, that we have two infectious disease doctors who are Filipino, and they are literally like the best internal medicine, everything doctors that I've ever dealt with, and very pleasant too, which is a rare combination. So she's walking up, and again, same kind of thing. Every day she remembers your name and, hey, how are you? How's everything going? How are the students? Any good cases? And I literally just pointed at her and I said, consult now, come here now. So she's like, hey, what? And so I walked out, put my hand on her shoulder and pushed her into the room. And I said, this lady has mucormycosis. Do you know what that is?
No.
Stumping us again.
Okay. So this is something, again, it's an educational thing. So mucormycosis is a fungus that grows in the nasal passages of severely uncontrolled diabetics because it's slightly acidic and a lot of sugar. And it is obviously catastrophic because it just basically, once it kicks in and starts to grow, it grows straight through your sinuses into the brain.
Oh, wow.
Okay. So if she wasn't having a nosebleed, that was CSF fluid leaking out. And I told the ID doctor, because obviously it's an infectious disease fungus. I said, this lady's got mucor. I need you to say, yes, she does, because the next step is neurosurgery, because all you can really do is cut the sinuses out. Oh,
wow.
It's catastrophic. It's literally like a high velocity gunshot wound to the skull. There's not a whole lot you can do.
Shit.
Never seen it before. It's one of the feared complications of type 2 diabetes. So in family medicine, type 2 diabetes is, one of our top things. If you spend any time reading outside of your standard, A1C goals and all this, you'll see that somewhere. Anyway, and I think there were some cases that probably, I don't think it's New England Journal, but I'd actually seen a few cases where they would show just like a bruise on the hard palate, and that was the diagnosis. It wasn't a bruise, that was the fungus, which appears to be green red. Yeah. So she comes in there again, very pleasant. She's not argumentative, and she says, well, that's kind of uncommon. I haven't ever really seen that myself. What makes you think that? And then I said, okay, here's the lady's nose. You see this fluid? She said, yeah. I said, that's CSF. She said, how do you know? I said, medical school, basic stuff, nosebleed, you drip the stuff, you drip it, and it's a different consistency than blood. It's thinner than water. I can't remember the pictures, but they used to show you the difference between water, CSF, blood on a piece of paper, how they kind of spread out. I said, just look how thin that is. It's slightly bloody, like CSF often is. Anyway, so then I said, now let's open her mouth. So we opened her mouth. Now the little area I had pushed had kind of dropped back down. So it just looked like that clot. And I said, here's what I did. I put my fingers in, and when I did, they went straight up into her sinuses. And she's like, no. She's like, no. You probably put your fingers into her posterior nasopharynx, and you're freaking out. She said, your fingers probably slipped back to the base of the nose. And you've just never done that before. And I said, okay, well, what do you think's going on? So she's real gently kind of looking and touching, and sure enough, her finger slides straight up.
Oh my gosh.
Straight up. And her eyes bulge. And she's like, oh my Lord. And I said, yeah. So she, again, real pleasant, she's like she went to finishing school or something. She's real polite. So she takes her gloves off with perfect, it's like her PPE protocols, so she washes her hands for 2 minutes under the thing, and then she walks out and goes into crazy person mode. So she starts calling. I don't know who she's calling. It's 6 a.m. And as she's trying to call somebody and she's hanging up and calling and hanging up, just so happens, here comes a neurosurgeon in the medical ICU. an older guy near retirement, and again, nice guy. And he's walking up, and he calls the infectious disease doctor's name. He's like, "Hey, Dr. So-and-so, how are you doing?" And she's like, "Oh my God, I'm so glad you're here. Come here, come here, come here." And now he's like, whoa, what's happening? And he sees me with like all these medical students, and he sees her, and everybody's eyes are bulging out of their heads and everything. He's like, what's going on? What's going on? So she's talking so fast, he can't understand her. She does have a little accent and blah, 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 blah. And he looks at me and he's like, what's happening? And I said, mucormycosis. He was like, no. And I said, yeah. So he goes in the room, he looks, he said, yeah, this is mucor. I've seen it once. It's terrible. I can't do anything for it. So he got on the phone and called our local kind of big fancy place is Vanderbilt.
Sure.
It's about 2 hours from here. In the air, it's about 45 minutes. We also have the University of Memphis, University of Tennessee in Memphis, which is kind of at that time was more known for its transplants and burns. That's where they actually did Stephen Jobs' pancreatic transplant over there.
Oh, wow.
Anyway, so he gets on the phone with Vanderbilt, and he's like, he doesn't know anything other than that this woman's got mucor, and he's doing his little neurosurgery chatter and secret code word password so they'll trust each other, whatever. So he was like, we need to get family because basically this is terminal. He said I talked to my my buddies at Vanderbilt, and he said basically what they do for this is they just go in. I'm trying to see if I can get my phone here without, it's kind of a profile shot. So he said basically they'll just go in and cut everything from here down to the jaw and remove it.
What?
Yeah.
Wow.
So basically the only thing that's remaining is the posterior portion of the brain and the brainstem.
Oh my gosh.
But they technically are alive. He said, but they have to have permission from the family, obviously, because that's, a lot of people would say that that's not recoverable. But
right.
Obviously there are other people that would say, no, a heartbeat's alive or whatever. And so he looked at the nurse and he said, who's her family? Of course, again, all we've got is an empty plastic, chart. We've got nothing. And now the morning shift is starting to come in for the nurses. And, so this nurse comes in, she's got her bag and everything, and she's just looking for the frequent flyers. She's like, oh, I see Miss Smith is back with her DKA, and we're like, oh, it's worse than that. And they're, oh, what is it? And we're telling her, and she's like, oh, that's terrible. And they said, oh, you know her? She said, yeah, I know her. And you know her family? Yeah. And they said, well, who's her? Any idea she have a husband? And she's like, no, she's got one daughter, and that's it. That's all. It's the only one I'm aware of. And I was like, well, do you know how to get in touch with her? And they're like, yeah, she's right next door in DKA.
Oh my gosh.
Yeah, intubated. Yeah, so her daughter was next door to her, intubated with severe DKA. Only family that we're aware of. So we can't deny her care at this point. So we arranged for a transfer to Vanderbilt for a, whatever you call that surgery. And then I guess fortunate or unfortunate, depending on your perspective, she died on the helicopter pad trying to get her loaded into the helicopter.
Oh, wow. That quick.
Yeah. So, mucormycosis, not, what's the medical term? Not uncommon or not rare. Well, I don't know how to say that. It's common enough that I had seen cases or read cases, but probably the only case I'll ever see, maybe the only case the medical students will ever see. One of the only cases the other two specialists had seen, and one of those near the end of his career. And I segued into that from a stage 4 breast cancer that presented as, atypical pneumonia or tamponade.
Yeah.
Wow.
How many of those residents hung on?
Well,
you kept them all.
Well, actually, yeah, they all graduated, did good. They did fine. We tend to be a little bit more hospital intense, or not intense, but hospital busy compared to traditional family medicine programs, which tend to focus on the outpatient scenarios.
Sure.
But I guess that's the pros or cons of being an isolated residency program in such a busy facility. But that was a unique situation. I don't think I ever had anything that close together. I think we actually published a case study on the Mucor because I think they were able to get a photograph. The hospital photography department or whatever AV department was able to get a real high quality photo of that pallet.
Yeah.
So I think we actually published a case study with that. And then Mucor is something that is, again, it's not uncommon, but it is something that is seen in a very small percentage of folks who are recurrent DKA. It can be type 2 or type 1, but it's just in people that don't ever seem to get their pHs and their sugars stable. And so, okay, all of us right now, if we did a deep nasal swab, is there Mucor in our sinuses? Probably.
Yeah.
But our pH is not 7.1 and our blood sugar is not 800. So we don't have the right fuel for it to grow. So I think it's one of those things where it's probably a ubiquitous thing. And for whatever reason, the compromised immune system, the pH, the sugar, or a combination of all three. But it is I guess it's like a catastrophic complication of uncontrolled diabetes that, with mental status change and DKA, it's something you have to consider.
Yeah. Well, thank you so much for sharing those cases with us. That was
This
amazing.
is always so enlightening and terrifying. So
yeah, for sure. You're a great storyteller. So thank you.
Yeah.
We got more.
Sure.
You got more for us.
Yeah, we'll have to get you back on.
That's just a tip of the iceberg.
Yeah.
Thanks so much, Dr. Ellis. This is good to meet you.
All right.
care.
Have a good rest of your day.
You too.
Bye.
Thank you to all our listeners. If you'd like to be notified when new episodes air, make sure to hit that subscribe button. And a big thank you to Pacific Companies. Without you guys, this podcast could not be possible. If you would like to be a guest, go to www.pacificcompanies.com. Thank you.